Vaccination in childhood. My name is Dr. Pathum Dissanayake. I am a senior lecturer in Department of Medicine of University of Peradeniya. And today I have prepared a lecture for the benefit of local medical undergraduate, and I will be providing some information in vaccination in childhood. So to deliver the lecture, I will first go to my objectives. The objectives are that first we will see we will take a general overview of vaccination. Then we will learn about vaccination schedule, which is available in Sri Lanka, both as part of the extended program of immunization and also outside this program. Then we will learn what are the contraindications for vaccination and what adverse reactions which can be seen during vaccination process. And finally, we will get some information regarding storage of vaccination. So what is a vaccine? A vaccine is a biological preparation that provides active acquired immunity to a particular disease by stimulating the body's immune system to recognize the agent as foreign, destroy the agent, and keep a record of it. Now these words which are highlighted are very important because it gives a summary of what exactly a vaccine is. First of all, it's a biological preparation and it produces active acquired immunity to a particular disease by stimulating the body system to recognize the agent, and also it helps the body's immune system to keep a record of it as well. So there are 4 major types of vaccines depending on what part of the cell has been used to produce the vaccination. So the first group is wholesale vaccines, where the whole cell of the organism has been used to produce the vaccine, and they are further subdivided as live attenuated and killed vaccines. Then there are purified macromolecular vaccines, which are further subdivided as toxoids, capsulopolysaccharides, and recombinant microbial antigens or subunits. Third type is recombinant vaccines, and fourth type is DNA vaccines. Under wholesale vaccines, we will first learn about live attenuated vaccines. These are live organisms which have the ability to grow, but the virulence has been reduced to prevent the disease. So it's a weakened organism. It can grow, but it cannot produce the disease. When compared with killed vaccines, these live vaccines produce stronger immune response. They are stronger than the killed vaccine, and they have longer immune response. So they are stronger and they have a longer immune response. Therefore, many does not need boosters. But this does not or this is not indicated in live oral vaccines, because many oral live vaccines need several boosters, for example polio and rotavirus. For injectable live vaccines, most of the time boosters are not needed. For example, live Japanese encephalitis vaccine is given only as a single dose. Live vaccines can very rarely cause the disease, especially in immunocompromised children, because it's a live organism, it has been weakened, but when it is given accidentally to an immunocompromised child, even the weak organism may be able to get activated and cause the disease because the host immune status is severely compromised. Live vaccines and killed vaccines, it can differ according to the route which the vaccine is administered, and these are the vaccines which we are using in Sri Lanka. So I have divided according to the route and according to the type, whether they are live or killed vaccines. So when you take the intradermal route, a description about these routes will be given at the middle part of this lecture. So intradermal vaccines, the live vaccine which is given intradermally in Sri Lanka is mainly the BCG vaccine. killed vaccines, which are given as intradermally, is the polio type 2 vaccine. Then there are subcutaneous vaccines, which is a common group. Live JE or Japanese encephalitis, then mumps, measles, rubella, or commonly termed as MR, and chickenpox. These are live attenuated vaccines. Killed vaccines, which can be given in subcutaneous route, include the killed Japanese encephalitis vaccine. So there are no live intramuscular vaccines available, but there are killed intramuscular vaccines which are available, and the vaccines against pertussis or the Salk type polio vaccine is a killed intramuscular vaccine. Oral vaccines, mainly they are live. For example, polio, the Sabin type, rotavirus and typhoid, they are all oral and live. But there is one killed oral vaccine, which is cholera vaccine. Then we will move on to purified macromolecules. There are three types of macromolecules which are used. One is a toxoid. Toxoid is a heat or chemically inactivated exotoxin. The exotoxin produces the disease, but when you inactivate it using heat and chemical substances, it can be used to produce immunogenicity. So it is usually given as an intramuscular vaccine, and common examples for a toxoid is the diphtheria and tetanus. The second group under purified macromolecules is capsular polysaccharides, and examples are pneumococcus and meningococcus vaccine. These are used to produce vaccines from organisms which have a polysaccharide capsule. Then recombinant microbial antigens or subunits, they are formed by cloning a gene producing an immunogenic protein and incorporating it to a harmless bacteria, yeast or mammalian cell. For example, hepatitis B surface antigen. So the hepatitis B surface antigen gene is cloned and it is expressed in a harmless yeast cell. Now we will learn about special terms used in vaccination, which as undergraduates you should be aware of. So the two common terms used is monovalent and polyvalent. Monovalent means protection for a single strain of a particular organism. So some vaccines are given only to protect the host from a single strain. Polyvalent means either protection against multiple strains of the same organism. For example, pneumococcal 23-valent vaccine. This means this is a polyvalent vaccine protecting against 23 strains. Or polyvalent can be used when a vaccine is given to protect several organisms. Another name given is combined vaccine. So MMR is a combined vaccine or a polyvalent vaccine where it is covering more than one organism. Then the term conjugated vaccines. You have heard this term, conjugation. Conjugation is use of a protein molecule which is attached to a polysaccharide capsule to produce immunity. Now these conjugated vaccines are used in children below 2 years because children below 2 years the immune system has difficulty in developing immunity to polysaccharide based antigens. In a child below 2 years, the immune system is capable of producing immunity to a protein based molecules rather than a polysaccharide. So what we do is we combine a protein to a polysaccharide to increase the immunogenicity of the vaccine. Adjuvant is a substance used in the vaccine preparation to improve the potency of the vaccine. For example, aluminium phosphate is a commonly used adjuvant which will increase the potency of the vaccine. Then a diluent. Diluent is a solution specifically manufactured to reconstitute a particular vaccine which comes in a powder form. Okay. So some vaccines for ease of prolonged storage, they are produced in powder form. So in powder form, you can keep the vaccine for a longer time in storage. But before it has to be injected, it has to be converted to a liquefied form, and the solution which is used to reconstitute this powder form vaccine is called a diluent. Then we will move into the vaccination schedule in Sri Lanka. This is called the Extended Program of Immunization, or EPI in short form. So in Sri Lanka at birth, we give the BCG vaccine, which is given as an intradermal vaccine. Then at 2, 4 and 6 months, we give the pentavalent vaccine. Penta means 5. So the pentavalent vaccine covers 5 organisms: diphtheria, pertussis, tetanus, Haemophilus B and hepatitis B. It is an intramuscular vaccine. With this pentavalent vaccine, we combine an oral polio vaccine as well at 2, 4, 6 months. And this oral polio is a bivalent oral polio vaccine. It covers polio type 1 and type 3. At 2 and 4 months, another intradermal vaccine is given. It's called the fractionated intradermal polio vaccine, and this covers type 2. So by giving a bivalent oral polio and an intradermal inactivated polio, we are covering against polio 1, 2 and 3. At 9 months, measles, mumps, rubella first dose is given, subcutaneous vaccine. And the same is boosted at the age of 3 years. So MMR second dose. At 12 months, we give a live vaccine for Japanese encephalitis. This is the only vaccine given for Japanese encephalitis. It's produced lifelong immunity, given at 12 months overpower. It's a subcutaneous vaccine. At 18 months, diphtheria, tetanus and pertussis is given to boost the ones which has been given at 2, 4, 6, combined with the oral polio 4th dose. Before school entry, the diphtheria and tetanus 5th dose is given with the 5th dose of oral polio. At 10 to 15 years, a final vaccine for childhood is given. At 10 to 15 years, ATD vaccine, or adult tetanus and reduced antigen diphtheria toxoid, is given as an intramuscular vaccine. So there have been some later changes to EPI schedule. The polio vaccine earlier was given as a trivalent vaccine, or trivalent means it covers all the polio vaccines type 1, 2 and 3. But currently we have a bivalent oral polio vaccine which covers only type 1 and 3, and to cover the polio type 2, a fractionated intradermal inactivated vaccine is given at 2 and 4 months. The reason why this change has been done, because type 2 polio oral strain is more prone to cause vaccine induced polio. If you give as a oral polio vaccine type 2, it is given as a live attenuated vaccine, and it has more potency to cause vaccine induced polio. So therefore, now polio type 2 is given not as a live attenuated vaccine but as a intradermal inactivated variant. Then recently human papillomavirus vaccine is introduced, and it is given to girls as a 2-dose regime 6 months apart, and the schedule is starting at the age of 11 to 12 years. What are the vaccines available outside the schedule? We have the hexavalent vaccine, which has come against the pentavalent vaccine. The difference between pentavalent and hexavalent vaccine is it has the same vaccines which are included in the pentavalent, that is diphtheria, tetanus, pertussis, Haemophilus influenza B and hepatitis B. But on top of that, it has inactivated polio as well. But this is different from the fractionated inactivated polio, which covers only type 2. This inactivated polio vaccine, which is included in the hexavalent, covers all 3 types of polio. Polio 1, 2, 3. Therefore, for a child who is getting hexavalent vaccine, we do not have to give the oral polio vaccine. Inactivated Japanese encephalitis vaccine is available, which is given as subcutaneous route. But this is a 4-dose schedule, and a lot of parents prefer the single-dose live attenuated vaccine over this inactivated Japanese encephalitis vaccine, which is not freely available anymore in the country. Varicella or chickenpox vaccine is available as a 2-dose schedule given subcutaneously for children above 1 year of age. The conjugated pneumococcal and conjugated meningococcal vaccines are available for children below 5 years. Rotavirus is available as a 3-dose oral live vaccine, which is given at 2, 4 and 6 months. Hepatitis A and hepatitis B are available as separate vaccines. Hepatitis B is included in the hexavalent vaccine, but there are isolated monovalent hepatitis B vaccines as well. So, what are the precautions which we need to take during vaccination? Vaccine should not be given if anaphylaxis was reported with a previous dose of the same vaccine. So, if a child has developed an anaphylactic reaction to a previous dose of the same vaccine, then that vaccine should not be given further. But if mild allergic reactions were recorded, only mild allergic reactions were recorded, the vaccine can be given, or the second dose can be given, but under close observation, preferably in an inward setting. Vaccines can be postponed if there are acute febrile infections present. If live vaccines given less than 1 month ago, because the minimum gap between 2 live vaccines should be 28 days or 4 weeks. If blood products or immunoglobulins were given within 3 months, this is for live vaccines. But from time to time, the guidelines are changing. Sometimes the 3-month period may be extended further. It can differ from one unit to another as well. If chemotherapy has been given within the last 3 months, then it's better to postpone the live vaccines. The other instances where live vaccines are postponed are sometimes after major cardiac surgery. The cardiothoracic surgeons prefer the live vaccines to be delayed for 3 months. Live vaccines are avoided in patients with reticuloendothelial system malignancies. They are usually avoided in the first 3 months of pregnancy and in children with immunocompromised states, obviously because the live vaccines itself sometimes can cause vaccine-associated illnesses. What about live vaccines and steroids? If a child is on high-dose steroids, high dose means more than 2 mg per kg per day for 2 weeks or more, then the live vaccine should be given 1 month after stopping the drug. If the child is in low-dose steroids, the vaccine can be given soon after stopping the drug. If the child is on steroid replacement therapy in physiological doses, or if the child is on topical steroids, the vaccines can be given while on drug. Then premature and low birth weight children, same vaccine with same dose at same schedule can be used as for term babies. There are no changes which are indicated just because a child is premature or low birth weight. Children with seizures, live Japanese encephalitis vaccine is not given if a progressive neurological disease is encountered. So live JE vaccine is contraindicated in a child with a progressive neurological disease. In a non-progressive disease, the live vaccine is delayed until he is seizure-free for 1 year. Right? Multiple vaccines can be given on same day but at different body sites. When vaccination is delayed or forgotten, multiple vaccination is helpful in correcting the schedule. For example, if a mother comes after forgetting 2 vaccines and she is due for the 3rd vaccine, okay, we can combine all 3 or at least 2 vaccines and given on the same day in order to catch up with the schedule. But the most important thing is it should be given at 2 or more different body sites. You can't give one vaccine to the same, more than one vaccine to the same site. Missed or delayed vaccines. There is no need to restart the schedule if a vaccine is missed or delayed. We have to give the missing vaccine as soon as possible using the multi-dose method at different sites. We can reduce the time between vaccines to prevent further delay. Minimum gap between two live injectable vaccines is 4 weeks. There is no specific gap between oral live vaccines, inactivated vaccines, live and inactivated vaccines. So by using this method, we can catch up with the schedule for children who have either missed or delayed the vaccines. So we can give multiple vaccines. We can reduce the time in between vaccines. Okay. So these are the two methods by which we are going to catch up with the normal schedule. Then we come to the next part of the presentation. What are the routes of administration? So oral route is a route which is preferred by both the vaccine recipient and the vaccine provider because it has no pain involved. It's used for the following live vaccines: polio, rotavirus and typhoid. The only situation where a live oral vaccine should be delayed is when the child is having a severe diarrhea, obviously because the vaccine will not be absorbed properly. Then intradermal route is method to commonly give the BCG vaccine, and the usual dose is 0.05 ml at birth. It is given to the skin with a needle at 15 degrees angle to skin, and if you do the vaccination properly, you will see a pale wheal of pale area or a pale wheal in the intradermal tissue plane. Subcutaneous is another common route for many live vaccines, and it is given at an angle of 45 degrees to skin. The usual dose is 0.5. The intradermal dose is 0.05, but the subcutaneous dose is 0.5. It's given with an auto-disabled syringe, and it's usually given at a 45 degree angle to the skin. The final route is intramuscular. It's a common site for most inactivated vaccines, toxoids and component vaccines. It's very easy to give because it is given at a 90 degree angle to the skin. Usual dose again is same, 0.5, and given with an auto-disabled syringe. The common sites for intramuscular vaccine are the deltoid and the lateral thigh. So these are the landmarks for the two vaccines. In the deltoid region, you need to first locate the acromion process, then measure 2 to 3 finger breadths below the acromion process and inject at the midline of the above point and a 90 degree angle. When you come to the lateral thigh, you have to select the medial 1/3 of the thigh and lateral to the midline. Okay. These two areas are devoid of major blood vessels and nerves. Therefore, injury to a major blood vessel or nerve is minimum. What are the adverse events following immunization? Adverse events following immunization can be divided into three groups: the vaccine events, program errors and coincidental events. Vaccine events are purely vaccine induced, for example anaphylaxis. Program errors occur due to an error in immunization process, for example injection site sepsis due to contamination. It is not directly related to the vaccine. It is due to poor skin preparation or using septic methods rather than aseptic methods. Then coincidental events are not related to vaccine but occur during immunization process, for example fainting due to a fear of needle. So prevention of program errors. Most common cause of adverse events are program errors. So how you can prevent them is by using the correct dose, correct diluent, correct route and correct site. Shake well when vaccines have to be reconstituted. Store properly. Avoid contamination and use sterility during injection. And always check for contraindications. Vaccine-related adverse events further can be divided as general events and specific events. The general events are allergic reactions, which can be either mild or severe anaphylaxis. Injection site reactions, which include pain, redness, swelling. Or general reactions like fever, shivering and headache. The specific reactions include reactions which occurs not with all vaccines but which are specific to certain vaccines. For example, when you come across wholesale pertussis, the specific reactions which are recorded include persistent inconsolable crying, hypotonic hyporesponsive episodes, seizures and encephalopathy, very common with wholesale pertussis, but this has been minimized using acellular pertussis vaccine, which is coming under the hexavalent vaccine. Measles vaccine sometimes can cause fever and rash and cervical and occipital lymphadenopathy. Rarely, some vaccination can cause Guillain-Barré syndrome. So what will you do as a medical officer when you come across an adverse event following immunization? So there's a notification form, adverse event following immunization notification form, or AEFI form 1, which should be filled and it should reach the medical officer of health of the patient's residing area, who prepares a monthly AEFI return which reaches the epidemiology unit, and finally they will start to investigate. But in a situation where there's a severe anaphylactic reaction, you can bypass these and directly even inform the epidemiology unit if you think it's a unique reaction which needs immediate attention. So vaccine storage and transport. Vaccines are sensitive to heat and cold. They should be stored and transported at the correct temperature from the time of production to administering. So from the time of production to the vaccination process, we need to maintain the correct temperature, and maintaining this correct temperature is called the maintenance of the cold chain. Usually the normal temperature for storage is 2 to 4 degrees. Vaccines should never be stored in the freezer of the door, and food and other products should not be stored with vaccines. These are the general rules in storing vaccines. You can't keep vaccines in the same refrigerator where you are storing food and other products. In a fridge or refrigerator, the freezer is used to store the frozen ice packs. The first shelf is usually used to store freeze-dried vaccines like the oral polio vaccine, MMR, measles vaccine and the BCG vaccine. The second shelf is used to store the DPT vaccine, diphtheria, pertussis, tetanus, hepatitis B vaccine, Haemophilus B vaccine and tetanus toxoid. The last shelf is used to store diluents and ice packs which are waiting to be frozen. No vaccine should be in direct contact with frozen ice. And finally, vaccine vial monitors. Some information about the VVMs. These monitors are used to detect heat damage to vaccine using a color regimen. So each vaccine will have a vaccine vial monitor. A normal vaccine vial monitor have a purple color circle with a square which is light in color. Okay, so inner square is lighter than the outside circle, and if you see this, okay, this indicates this vaccine is properly stored and it is ready to use. The inner square will start to become darker, but still in this situation you can still say that this is paler than the outer circle. This means the expiry date is near. You check the expiry date. If the expiry date has not been surpassed, still you can use this vaccine. But in a color coding of the VVM, if you see the color coding in this position and the expiry date has been passed, then you can't use the vaccine. Sometimes the vaccine vial vaccine vial monitor might say that there is no square to be seen. Inner square matches the color of the outer circle. Then we cannot use this vaccine even if it has not gone beyond the expiry date. If the inner square is darker than the outside circle, again we should not use the vaccine. So the only situation where I use the vaccine which indicates to us that the cold chain has been properly maintained is that the vaccine has not gone beyond the expiry date and the inner square of the vaccine vial monitor is paler than the outer circle. So with that we come to the end of the presentation, and now I will give you a summary of the presentation so far. So today we have learned about vaccines and the types of vaccine according to the immunogenic component used for preparation of the vaccine. We learned that the efficacy of a vaccine depends on the schedule used, the type of vaccine, the presence of adjuvants and conjugating molecules. We learned that there are different routes available, but each having specific advantages as well as disadvantages. We need to take precautions during vaccination, and we need to know what to do when vaccines are missed. So we can either use multi-dose regime or we can reduce the dosing interval to catch up with the schedule. And finally, we learned the importance of proper storage and maintenance of the cold chain and how to use a vaccine vial monitor to find out whether a vaccine is suitable for use or not. Thank you.